Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Hello, my name is Kayo Takahashi from Riken, Kobe, Japan. First of all, I would like to thank all of you who organized this committee despite of these difficult situations. Thank you very much for giving me this great opportunity. So let me start my presentation. The title is Aromatase in the Brain and the Human Personality. So it is known that sex steroids can affect emotion or mood and disorders. For example, fear, anxiety, panic, and PTSD, depression. The women are more vulnerable to these disorders or disease. So it is thought it's because of estrogen fluctuation in women. So there is several evidences for that. For example, here, estrogen can affect the serotonergic system. So this graph shows the level of messenger RNA and the protein of tryptophan hydroxylase. This is the important enzyme for producing 5-HT, serotonin. And the animals are female rhesus monkeys. So the ovary, when the ovary removed the messenger RNA and the protein of tryptophan hydroxylase, it decreased like this, but when they were treated with estrogen or estrogen and progesterone, it is recovered. So the estrogen is very important for serotonergic system, it shows. So this is our previous report. So we treated the male rhesus monkey with anabolic androgenic steroids, nandrolone. So actually this is a drug for doping in sport, you know. They can increase muscle mass, and also they have some psychological adverse effects like irritation, aggression, and hostility. Unfortunately, we could not do any behavioral test for this rhesus monkey because of our shortage of facility. So, but we performed 3 weeks treatment with this AAS to rhesus monkey, and we performed the PET study before treatment and post-treatment. And then we found the increased aromatase in their hypothalamus after 3 weeks treatment with nandrolone here. So we think there is some relation between aromatase in the hypothalamus and aggression. We recruited the healthy volunteers, the 11 men and 10 women. And they were asked to answer the questionnaires. One is the Basperi aggression questionnaire for assess their aggression, and also the temperament and the character inventory for assess their personality. And the PET scan was performed for 60 minutes. Just they were lying in the camera and no task. And we injected around 270 megabecquerel per body. And also, we collected their blood and we measured their steroidal hormone in blood, testosterone or estradiol. This is a PET images with this tracer carbon-11 labeled cetirizole in men. So this is a horizontal slices, and it starts from the cerebellum and go to the top of the head. We can see clearly the high accumulation of this cetirizole in the thalamus especially, and also amygdala and the hypothalamus as well. And in women, the distribution pattern is same, the high accumulation in the thalamus and the amygdala and the hypothalamus. Actually, amygdala and the hypothalamus, the mouse and the monkey had the same distribution pattern, but the thalamus is very unique. So I would like to summarize. First, high accumulation of carbon-11 labeled cetirizole was observed in the thalamus, hypothalamus, and the amygdala. So it means that there are high level of aromatase exists in the thalamus, hypothalamus, and the amygdala. And the thalamus is unique in human as an aromatase-rich region. Actually, we think this is interesting. The aromatase level in the thalamus showed association with higher brain function, such as cooperativeness. So it's, of course, the monkey has cooperativeness as well, but I think this is can be characteristic for human. And positive correlation between aromatase level in the female amygdala and the aggression, and negative correlation between aromatase level in the thalamus and the cooperativeness. Some associations may differ between sexes, while others are likely common.
First off, I'd like to thank the organizers of the CIMP for their invitation, and to thank Mark Weiser for including me in this interesting session. Today, I'd like to focus on some of our investigations of the role of estradiol in both the onset of depression during the perimenopause and its role in the pathophysiology of this condition. First off, I have nothing to disclose. And what I'd like to focus on today are two questions: our efforts to define the hormonal characteristics of the endocrine conditions that could trigger an episode of perimenopausal depression, and then finally to our efforts to determine some of the biological underpinnings of the differential sensitivity in perimenopausal depression to otherwise normal endocrine events. So first is some background. The menopause transition is associated with a 2 to 3-fold increase in the risk of both first onset and recurrent depressions. And these have been identified in longitudinal prospective community-based studies. Similarly, in those studies, episodes of depression tend to cluster during the mid to late menopause transition and the early postmenopause, when estradiol levels are either declining or are low. Finally, estradiol therapy has been shown to have both acute antidepressant effects independent of estradiol's actions on hot flushes, as well as a recent study showing a preventative effect of estradiol in perimenopausal depression. The other element of this is that studies from the WHO, or the Women's Health Initiative, have reported that the presence of even a minor depression during the post and perimenopause is associated with a 50% increased risk of mortality due to cardiovascular disease in women who develop depression. And this is controlling for other risk factors that are relevant for the onset of cardiovascular disease. This is an example of the pattern of symptoms that we observed. These are on the y-axis are the severity scale for the Center for Epidemiologic Studies depression scale, where higher scores are consistent with more severe forms of depression. On the y-axis, each bar represents a week in the study that we followed each of these women in the clinic. And focusing on the middle panel, that you can see these are the women who underwent or crossed over to placebo and underwent estradiol withdrawal. And you see during the 3 weeks when they're on open label, that when they were crossed over, there was a significant increase in their levels on the CESD scale. We found this in several of the other scales. In contrast, women with a past perimenopausal depression who were maintained on estradiol showed no similar flare or recurrence of their symptoms. And the control women, the women with no past history of depression, they experienced no change despite being crossed over to estradiol. So what these findings suggested was that there was a differential behavioral response to the otherwise identical change in estradiol going from higher levels to low levels. And we pursued these findings first. I'll discuss in a study that's ongoing, and we're still blinded, to look to see whether these effects of estradiol withdrawal on mood are mediated by estrogen receptor alpha or beta. Second, in my latter part of my talk, I'll be talking about some of our studies in which we've looked to see whether there was an intrinsic cellular difference between the women with the past perimenopausal depression and those who had no history of depression with regards to their response to estradiol. So our current study is similar to the one that I just presented you, that we're recruiting women who are postmenopausal but who have had a well-characterized past episode of depression during the perimenopause. All women are placed on a standard dose of estradiol at 100 micrograms a day by skin patch. And after 3 weeks, if they remain asymptomatic, a third of the group is crossed over to placebo, where we would demonstrate then what we saw in about 70% of women in the previous study will experience a recurrence of their past perimenopausal depression, whereas the other 2/3 of the sample will receive one of two doses, either 25 or 75 milligrams of this compound, the LY500-307, which is a selective estrogen receptor beta agonist. So as I said, this study is continues to be blinded. We're about recruited about half of the sample in the midst of the quarantine and a variety of other challenges that we've had to get this going, but we seem to be moving on now, and hopefully everybody will keep wearing their masks and washing their hands and socially distancing, and we'll be able to finish this study sometime in the next year or so. So just as a reminder, we follow them then at week 11 to ensure that their estrogen, whether they need to go back on estrogen if they had stopped it. Many of the women choose to do that because they feel so good on the estradiol, and they're older, so some of them don't require a progestin. But as well, just to make sure that they are no longer symptomatic. And in most cases, they are not. So the idea behind the study is whether the estrogen receptor beta agonist will mitigate the effects of estrogen withdrawal on symptoms similar to what we saw in our previous study. But she had difficulty finding, because of probably a small sample sizes, that when we looked in the plasma of the women who had done the study, that even though there were several women with very high levels of CXCL10, it was not sufficient to use as a marker. So what we're planning on doing then, we have just completed a longitudinal study in over 88 women who were followed from the premenopause. This is a spaghetti graph showing the number of participants. And in the blue dots at the bottom shows the onset of depression in about 22 women who developed this prospectively during the study. And we'll be looking at whether CXCL10 and some of these other markers that Sarah's identified are in any way associated with perimenopausal depression. So just the conclusions I've discussed, we've identified CXCL10 as being very important in this condition and possibly in the comorbidity and the risks for cardiovascular disease. and we will continue to focus on it as well as our studies on ER beta. So with that, I'd like to thank you and for your time